to the cloud somewhere. You might see it floating up there. Okay, let's talk about postpartum. So we've had our client go through labor, okay? And she had a difficult labor. And we're going to talk about what our priorities are during the postpartum period, the immediate postpartum. So as soon as that placenta is delivered and she's still being cleaned up and baby's on her chest, if she's breastfeeding, she's starting to breastfeed already, and bonding with baby. We clamp the cord. And so the details of what we do with the baby, we'll talk about in week 7. Next week, we're going to start talking about the ante and the intrapartum high risk issues. In other words, clients with chronic diseases. How does that affect the pregnancy? And then things that can occur during pregnancy that lead to high risk. So it's a very complex week next week. So let's talk about our client today. I'm going to share my screen here. Okay. So do you remember our client, Abby? She was, let me see if I can do this. Where's my cursor? Nothing like a missing cursor. Where are you? There it is. Do you remember our client, Abby? 40 years old, right? And she had in vitro fertilization. She had not been successful having children on her own throughout her 30s when she was trying. And so she went through fertility studies, and usually those women that have in vitro fertilization, they are considered high risk of losing the baby and then going into preterm labor. But our client was able to carry her baby all the way through 42 weeks. She did not want to deliver any earlier than 42 weeks, which is the beginning of post-term. So post-term pregnancies, the placenta is getting old. It's been working hard for 40 weeks, and it's beginning to become less efficient in what we call it calcify. So some of the blood vessels in the placenta aren't as readily available. Okay, so she comes to labor and delivery to be admitted. She thinks she's in labor, and we have gotten her through labor, and she received an epidural. She ended up getting an epidural anesthetic, and she was in labor for 20 hours. And we call that labor dystocia, difficulty. The word dystocia means difficulty. It's part of the reason she had difficulty is because she was postpartum and because of her age. Okay, and she had a big baby by then. And she sustained a laceration in her pelvic floor, the vaginal area, the vaginal muscles at the bottom. If you were to examine her vagina down at the bottom, we call that the posterior wall. And sometimes it'll actually tear all the way down to the rectal muscle, but hers wasn't that deep. So because she tore, she had to have immediate repair work right after the baby was delivered. So she sustained a little bit more blood loss than what we would expect in a vaginal delivery. Average blood loss is only about 500 ml for a vaginal delivery. Now for a cesarean, it's going to be closer to 1,000 ml. Okay, so Abby sustained 700 ml blood loss, and it was because of that laceration. So we have some extra duties as a nurse for her. She did begin
I'm sorry,
skin.
Professor, can you repeat the blood loss for vaginal?
Yes. Yeah, so for a vaginal delivery, usually a woman will lose about 500 ml. Okay, and for a cesarean delivery, it's closer to 1,000 ml. Okay. Nithya, you want to turn your camera back on, please?
Is it on?
So, oh,
Oh.
I was talking to Nithya. We have a Nisi and we have a Nithya. There you are. Okay. So even though she had a tear and we had to do surgery, during that surgery, we were able to allow her to do skin to skin with her baby, and she wanted to breastfeed. So the nurse was working with her on breastfeeding. So because of what she sustained, what concerns should you have as a nurse for the postpartum period as far as her safety and well-being? And this is a very open-ended question. Okay, so she went through in vitro fertilization. She had a difficult labor. She's 40 years old. She's exhausted. She's got mixed emotions because she's excited, but she's probably a little anxious. So what are some concerns you have for her? Can you think of anything that comes off the top of your head? Well,
Blood loss would be one if it's over the normal.
okay. Okay, so we're concerned about the amount that she did lose. Okay, so she's going to be a little anemic. We want to make sure that an order is written for a hemoglobin, a follow-up hemoglobin. Okay, we certainly want to make sure she's getting the fluids and drinking. We want to encourage good PO intake to help regain some of that loss. Okay, so it's 6 o'clock in the evening or 1800 hours, and you walk into the room. You're the nurse. Okay, you're the postpartum nurse, and your client is lying in the bed. And when you enter, it's been 30 minutes since you've been there, and there are some cues to indicate that you need to follow up with something. So in this next section, it tells you that the client is diaphoretic. She's asleep, but she wakes up when you touch her. Okay. She says her pain is 4 out of 10. Her fundus is midline. Okay. It's 2 centimeters above the umbilicus. It's soft, and you don't feel the fundus contracting. Blood is found on the bed sheet. Your client says she has not voided for 4 hours. The newborn is lying quietly asleep, supine in the bassinet, which is the most appropriate position. What are some things you're concerned about?
The fundus should be firm, right?
The fundus should be contracting and firm, yes.
Hemorrhaging.
Yeah, it could be. Yeah, she's obviously bleeding. If you see blood on the sheets. Okay, what else?
The voiding for 4 hours or not voiding.
Yeah. She's not been up to the bathroom. You've already explained to her she needs to get up every couple hours at least to keep her bladder empty. Okay, what else?
That's diaphoretic.
Okay, diaphoresis.
She might maybe need some fluids.
Okay. Remember during pregnancy, her blood volume almost doubled, a lot of plasma, a lot of red blood cells. Once that baby is born and that placenta is released, the placenta provides estrogen and progesterone during pregnancy. Now that it's removed, her levels of progesterone and estrogen drop dramatically. Okay. And the reason that she's diaphoretic is because of the loss in estrogen, and she's getting rid of all that extra fluid. So the blood that was in the uterus has either been lost, through the vagina, or it's been recirculated back into her systemic circulation. So she's just getting rid of all the extra fluid. So diaphoresis and diuresis. So diaphoresis is sweating, perspiring. Diuresis is urinating a lot, maybe 3 liters a day. And this is very common. It's very normal for postpartum. Okay. We want to see them diaphoresing. Okay. it's a good resolve to delivery. Okay. But she's not emptying her bladder. So what do you think it should be your priority at this point? You have all this data. You read our little scenario, and this is the kind of thing you're going to see on the NCLEX. You're going to be given a case, and you're going to have to pick out what about that scenario you need to make decisions on. You need to decide what is a priority. What should you do as a nurse? Okay, so you want to always think about physiological safety. That is Maslow's hierarchy. Okay, physiological safety is most important. Okay, so what do you think in this list? Let's label these I think there's 1, 2, 3, 4, 5, 6, 7, 8. Which intervention should the nurse make a priority?
Massaging the fundus.
Okay. Whoops. Problem with me doing this is I can't put number 1. Okay, let me do this.
Roll client to lateral position.
So we're going to massage the fundus. Now, when you talk about roll the client to the lateral position, what is that doing?
Doesn't it open the vessels? Or relieve from pressure?
I think it improves cardiac output.
Can you repeat the question, Professor?
Yeah, which one in this list is a priority? Now, rolling the
IV
client,
bolus?
IV bolus is another good choice. So rolling the client to the lateral position is not appropriate anymore. We don't have a uterus. I mean, we have a uterus. We don't have a big baby in there. Okay. It's kind of hard, isn't it, to determine what's first? So number 1 cause of hemorrhaging in the postpartum, or I should say this differently, the number 1 cause of mortality in peripartum is hemorrhaging. Okay, because this is usually the reason women don't survive, is they bleed out, and that hemorrhage is not recognized early enough. If you wait until you see your client's blood pressure drop and her heart rate become tachycardia, it's a late sign. Okay, she's already lost a lot of blood. So as nurses, we're very astute. As postpartum nurses, we know that these women bleed easily. So we need to intervene and plan to intervene early. So we have a routine we do.
What about the
Massage number-
medication?
Administer
Administer the
tonic.
uterotonic medications,
Okay,
because that's used after
okay.
the birth.
So in your assessment, in the slide before, it says that the fundus is soft and above the umbilicus. Where should it be after delivery? Does anybody know? It's above, and I'll show you a picture. It should be right at that umbilicus, or just 1 centimeter above, maybe. 2 centimeters means that it's not contracting. It's not what we call involuting. Okay, it is midline, and that's good. So when you know that if she had an epidural, she does not have the sensation necessarily that her bladder is full. Okay, she doesn't know she needs to urinate. She forgot. So the first thing we need to do is get her on a bedpan. Okay, because that bladder is distended, probably in full of urine, and the uterus is having trouble contracting. So let's get her on the bedpan. So in this scenario, I gave you all kinds of choices. Okay. And most experienced postpartum nurses are multitasking. They know they need to get someone else in there to help them do all these things. Okay. It's only been 30 minutes and yet she's bleeding. She's not contracting. So let's sit her on the bedpan since she had an epidural for safety purposes. Let's sit on the bedpan and let's get somebody to massage that fundus. Okay. So we're going to put this in here. Okay. So we're going to have this be number 1. And then doesn't do any good to massage the fundus if our bladder's full. It gets in the way. Okay. That bladder is up in front of that uterus almost, if it's pretty full, and it doesn't allow that uterus to really contract. Okay. So we're going to empty the bladder. We might have to use a Foley if she can't void. And then we're going to begin to massage that fundus. So we got that going, and we're calling for some help, get somebody in there so they can help do some things. Okay. And then somebody mentioned IV fluid. Let's go ahead and get her some IV fluid going. What else do we want to do right away? We've got that started. What else can we do it? We're not going to roll her over, so that's not essential.
What
What
about the
else?
medication? Doesn't it stop hemorrhaging? Helps?
Okay. We probably should go ahead and give her
Or
some
give some
oxygen.
oxygen.
And Nikki, we're sending somebody to go get some medications. Okay.
Thank you.
Now, in your simulation that you do for hemorrhagic shock, you're doing this scenario. Okay. You're doing this. So you have your team in the room and you're the team lead. This is your client and you're barking orders at everybody. Okay. So then we're going to give her some uterotonic medications. And when we get her all comfortable and cleaned up and things are under control, her uterus is contracting, all is well, then we can change her sheets. Unless you have somebody who can do that while you're busy doing the important stuff. Okay. We also have another thing we need to do, and that's weigh the pads. If there's a lot of blood on the sheets, you can't really weigh a sheet, but if she's on a chuck or a draw sheet, you can't weigh that, but you can weigh a chuck. Okay. So we need to weigh to know approximately how much blood she's lost. So that's how we make decisions. Okay. So some uterotonic medications.
Go back, Professor.
Yes.
Just go back. Let me just take a picture. You move so quick.
Okay. I'd be glad to slow down for anybody.
Thank you.
I'm recording this too, so I'll post it in week 4's announcement.
Okay, go ahead. Thank you.
You're welcome. Okay, so uterotonic medications. Let me ask somebody, Emily, which one of these, no, there's more than one. Which one would you choose as your first choice in a uterotonic medication? In other words, you're going to increase the tone of the uterus. Uterotonic, you want it to contract. And some of these medications cause that to happen. Which one do you think you would use? And by the way, everybody, make some drug cards with these, okay?
I'm gonna say Metrogen.
Miss Protol.
Okay, we can do misoprostol.
Mr. Protol.
Actually, it's pronounced miso. I like miso because I like miso soup. No, misoprostol. It is, what kind of a drug is it? Does anybody know?
It's a cytotic.
It's Cytotec. Yeah, Cytotec is a brand name. Cytotec is a drug that was given quite a few years ago for people with ulcers. It helped coat the stomach, but we use it in OB because it helps the cervix to soften, and it often at high doses it causes uterine contractions. So we give it as a rectal suppository at a high dose. Okay, so it's a prostaglandin. That's what the P means. Okay. Is there any contraindications to prostaglandins? Does anybody know? For our client? To put a rectal suppository in our client?
Yeah, she had tearing that went that far.
Yeah, good, Mitchell. Good. Yeah. Contraindications would be an episiotomy or a laceration. You don't want to put anything in the rectum. If she has some tearing and sutures, you might dislodge those sutures. So the contraindications, and there's really no adverse effects. Okay, good. Oh, just to let you know that they did okay to leave mifepristone on the market. You know, these two drugs, misoprostol and mifepristone, are two drugs that they use for medical abortions. Okay, misoprostol just causes contraction. Okay, and then the mifepristone causes that baby to stop growing, along with there's other things that they can use. So misoprostol, we use it other times in pregnancy too. Okay, which one of these drugs do we have perfusing during labor?
Oxytocin.
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 Yes. Oxytocin is a hormone, okay? And it's a natural hormone, and we also we infuse it. Once that placenta, if actually right after that baby is born, when the placenta, the uterus continues to contract, we might give a bolus of oxytocin at that time. And anesthesia, if they're doing helping with the procedure, they're going to hang a bag of Pitocin that's a higher dose, and we're going to run it a little faster because we want that uterus to release the placenta, and we want that uterus to continue to contract to stop the bleeding. So usually oxytocin during the postpartum period, even though she's getting an IV, we can also give it intramuscularly. Okay, during the postpartum period. There's really no contraindications unless she had uterine repair. She had a torn uterus or something like that. We wouldn't do it. Okay. So we can give her a dose of oxytocin intramuscular. What other, is there any other uterotonics in here?
Hemabate.
Hemabate. Okay. How do we give it? Do you know what the route is?
IV.
No. It's also intramuscular injection. Any contraindications?
Asthma.
Asthma. So if our client has asthma, we can't give Hemabate. So what happens? It causes bronchostriction. Bronchostriction, I think that's how you spell it.
Yeah, tightness in the chest.
Yeah, difficulty breathing. Anything else in this list?
Methergin as well.
Yeah, Methergin is one too. There's a lot that we can use. Methergin is a very potent vasoconstrictor. We also give it, very common drug. If we have a client come in and she had a miscarriage And we do a D&C, a dilation and curettage in surgery. Usually we give her methogen or methylergonavine at
Does
the end
that
of the
help to
procedure.
deliver, it helps them deliver the placenta? Methogen?
It could, but usually we use Pitocin,
Okay.
but you might see it used after the placenta as well. And that's a provider preference. Okay, any contraindications to Methergen?
Hypertension.
Yeah, if she has a history of high blood pressure or she developed high blood pressure during her pregnancy, she had gestational, or if she had preeclampsia, we don't want to give her methylergonavine. So it increases the blood pressure.
The hemobate, is that for blood loss or contraction?
All of these are same thing. Okay, so what we're trying to do is get that uterus to contract. So we can use all of these drugs except for the magnesium. Okay, they're all considered uterotonics. Okay, we want the uterus to contract because remember, when that placenta pulls away from inside the uterus, those maternal blood vessels that were interfaced with the placenta is delivered, and now those blood vessels are exposed and they're bleeding. So we need to have the uterus contract to squeeze up those blood vessels to stop the bleeding. So all of these drugs, except for the magnesium sulfate, will cause the uterus to contract. So we can hit her with all these medications, and we usually do. I think we can give the methylergonavine every 4 hours. So if she's still bleeding more than what we want, we can give her another dose. So make sure you do drug cards on these. You need to know these drugs. Magnesium sulfate, who knows what kind of drug that is? Who knows what kind of drug magnesium sulfate? Anybody know? Just curious.
Is it useful for them to go to the bathroom? Help them go to the bathroom like a laxative?
Okay, magnesium sulfate, we'll do that orally. We can give it, and magnesium oxide, we do give those for help relax. Yeah, it's a central nervous system relaxant. It relaxes skeletal and smooth muscle. Okay, so you'll learn more about magnesium sulfate in week 5, in week 6, and 7, and 8. So we will be talking about this wonderful drug for a long time. Okay, somebody's got some.
Hot mic.
That's okay. I muted you. Okay, all right. So we've got our drugs on board and you are reassured. So we're going into the room. Remember, we're looking at the fundus. Where is it? Palpate it. Is it soft? Is it midline, or is it deviated to one side? So when we talk about complications in postpartum, we're going to go over this again. Okay, so this is the first time you're going to see this information. So if we go in the room and the uterus is nice and firm, so let's say you did go into Abby's room and her uterus she had been up to the bathroom, her uterus was firm and it was contracting, but she was still bleeding. So if we know the bladder's empty, the uterus is contracting, and yet when we go to do our assessment on the perineum and the lochia, she's still bleeding. So we do have to determine, even though her uterus is contracted, doesn't mean she's not bleeding. There's other causes of bleeding. So what could that cause be, Mitchell? You mentioned it earlier. You're muted because I unmuted you. I mean, I muted you.
Oh, sorry. Yeah, can you repeat that? I was writing some notes down. So
Okay. Do you want me to repeat anything?
yeah, the question that you just asked.
Okay. So if we go into your client's room And you do your initial assessment, your priority, which is the uterus, the fundus, and it is midline, and it's right at the umbilicus. It's firm, the uterus is contracting, and yet when you go to assess the perineum next, the lochia, how much is she bleeding? You find that she's bleeding a lot. Well, does that make any sense? Her uterus is contracting. She shouldn't be bleeding a lot.
Should
Well, I
be
mean,
clear.
if she has some trauma in there that maybe they didn't catch or something, if it's internal.
Okay, so remember she had a laceration. So
Mhm.
it could mean that one of the sutures came loose. So what would you do in that situation? First thing,
Contact the physician.
yeah, call the provider.
suture.
Call the provider, because there's not much you can do other than give her fluids and put her on some oxygen and wait for the provider. And you could clean her up and maybe apply some pressure, maybe an ice pack until he or she got there. Okay, so she could be bleeding because of a laceration or something else, trauma that wasn't noticed, as Mitchell said. So the postpartum assessment starts with the fundus. Okay, you're not going to do neuro assessment. You're not going to go do a complete cardiovascular assessment. You're going to the fundus, because that is the most important piece of information you need. And the most important thing to do postpartum is to make sure that that fundus is contracting. And then you go to the lochia. Look at how much she's bleeding. Look at the perineum. Okay, so for the lochia, we oftentimes will just use a subjective observation. If she saturates the pad within 30 minutes, she's hemorrhaging. Okay, that's too much bleeding. A moderate amount, a small amount, a scant amount. So lochia rubra is usually what you will observe as long as the client's in the hospital. And usually they go home within 48 hours. They're allowed to stay longer if they need to. That's a government, that's a law, federal law. She can stay as long as I think 72 hours if she feels like she needs to. So the lochia lasts 3 or 4 days. After that, it does begin to lighten up. Remember that area where that placenta was attached, all that residual, we call it, has to slough off. So it does lighten up, and it's called serosa then for several days. And then the last 3 weeks or so, it's called an alba, because there's not much of anything but white blood cells left. So we're going to teach our client these things. You should slow down on your bleeding by, within 5 or 6 days. So your team was very successful because you've been working together for a while. You're very experienced. And fundus is contraction nicely. And we did the assessment. Look at the picture over here. And this is in your book as well. This shows you the uterine fundus as it involutes. Okay, the word involutes means to shrink back to the pre-pregnancy size. And while it contracts, it takes a couple weeks for it to get down back behind that bladder. So all the bleeding is under control. Her sutures are intact. There's no problem. She's breastfeeding and she's complaining about worsening cramping when she's breastfeeding. How should you respond? What's causing her increased pain when she's breastfeeding? She says she's having her uterus, her stomach hurts worse when she breastfeeds.
That's normal, right? Or common.
Yeah, it's normal. What's going on? Do you know what's going on what happens when she's breastfeeding?
That's a hormone thing that
Yeah,
released during breastfeeding.
Exactly. So we're back to oxytocin again. So oxytocin has a second purpose, a second function. When the baby suckles and breastfeeds, it stimulates the brain. The brain tells the uterus to contract. Okay, so breastfeeding will cause uterine contractions too. So another
I have a
benefit.
question about the fundus. If it needs to be massaged, I know that circumstances can, dictate something different. What is the normal? Is it just a one-time thing, or is that something that you're going to have to come back and do multiple times on
Yeah,
a
you're gonna-
normal basis?
Yeah, initially, your first assessment, your first 30-minute assessment, you might have to do more massaging because she might have some retained clots or something in there. Okay, we need to express all the clots out of that uterus so it can contract. If there's something in the uterus, like an infection or just leftover tissue, it's going to have more trouble contracting. So you're going to do it more initially, and then when you come back on your rechecks, you want to massage, make sure it's firm, and then check the lochia on your subsequent assessments. Yeah. Okay. So yeah, the oxytocin, remember, we give it to her, but she has it naturally, comes from the posterior pituitary. It's endogenous, okay? So that when she does breastfeed, the brain releases oxytocin. And that oxytocin allows the milk to be expressed from the nipple, and it causes the uterus to contract. So we're going to explain to her, we call those after pains. After pains. So now that we know the uterus is good, the perineum looks good, there's no problems there, what do you think is your next important assessment? We did the perineum, right?
The attachment of mommy and baby?
Okay, we kind of do it, simultaneously. Yeah, we need to check her breast. So when you're done the priority assessments, you're going to wash your hands, change your gloves, and put on a clean pair of gloves. You need to assess and teach her about deep vein thrombosis as well. Okay, we want her moving her legs. So ambulation is really important after having a baby. Helps keep that blood flowing and helps prevent DVTs. If you have a client that had a cesarean section, until she's ambulating, she's going to have those sequential compression devices on her legs. You know what I'm talking about? We wrap this fabric around her legs, and it's attached to tubing, and it alternately pumps the legs. In other words, it mimics muscle movement. And we do that for any client going to surgery, abdominal surgery, okay, any kind of pelvic surgery, hip surgery even, orthopedic, total replacements. So we do, and even heart surgery, we do all that. If they're going to be in surgery for quite a while, even if we're doing back surgery, we're going to put the SCDs, the sequential devices on her legs to keep those legs moving, help prevent blood clots. So we're going to look for, what's an early sign of a developing DVT, deep vein thrombosis? What's an early sign?
Redness, swelling, and pain.
Okay, she could be having some pain, some edema in that leg. If she has a blood clot in there, it's going to collect fluid, so that leg is going to become a little edematous. And redness, we call that erythema in that area, usually in the calf, okay? And then palpating it, it might be a little warm. So you know that you need to, as a nurse, measure. Okay, so you get a skin marker, get a tape measure and measure that leg. Mark where you're measuring. Okay, you're going to mark that part of the leg where you're measuring. Measure the other leg and compare it. Document the circumference of that calf muscle so that when you come back an hour later, so you can remeasure right where you measured before and see if the heparin is helping that clot to begin to resolve. Okay, we usually give heparin. We might give a bolus of heparin, IV bolus, just push it in, 7,200 units, like your first set of calculations. And then we begin a maintenance solution, 50 units an hour, what was it? 1,500 units an hour, something like that, based on her weight. So she doesn't have any DVTs developing, and we've examined her breast. We've educated her about latching with baby. We're observing mom to see if she is interacting with her baby. Is she bonding? Is she talking to the baby? Is she showing eye contact? Is she interested in caring for her baby? What if she didn't show interest at all? What would be your concern? What could she be? What could be occurring if she loses interest in caring for her baby?
Postpartum depression.
Depression.
Okay, so usually those first 2 weeks postpartum, we call it postpartum blues. Okay, if it goes beyond those 10 days to 2 weeks, then it's more of a depression. Okay, now if your client has a history of bipolar or something, then it probably could be, it's probably depression during hospitalization, but we usually refer to it as blues during the first 2 weeks. And then more of a depression. Okay, and then when we talk about high-risk complications, we're going to talk more about the pelvic floor, about vulva, some hematomas that could occur. Hematomas and lacerations are the second cause of hemorrhaging after delivery. And then hemorrhoids. This is a picture of internal hemorrhoids. And we need to certainly assess the rectum if she has a history. Okay. So we don't have much time left. I did send you a complete PowerPoint of postpartum that's different than this case. Okay, it's got, it goes through postpartum assessment. It talks about the postpartum blues, depression, and psychosis, which we talk about again with high risk. Okay, so a lot of the information from today, we're going to repeat. We're building on from week 1. Okay, our history, our client history. What's the background? Okay, we take our client through antepartum. What testing do we need to do? How do we monitor our client through the antepartum? What education do we need? If we have a diabetic client, what are we doing for her? What would we see in that antepartum? What would we expect during the intrapartum? And then how do we handle it in the postpartum? So we're building on our complete knowledge so that next week when we meet, we are going to talk about diabetics. Okay, we're going to talk about the development of hypertension during pregnancy. Usually that second half of pregnancy, some women just develop high blood pressure. Some of them develop what's called preeclampsia. So we're going to talk about those other issues. And we're building on our normal client so that by the time we get the baby, then you'll see how that affects a fetal outcome. Okay, so helping you just put all this together. Let me look at the chats here. Okay. Okay. So look at that postpartum assessment PowerPoint, and because we're going to be talking about mastitis, endometritis, infections next week. Okay.
Where
Did
did
you
you
look
put that
up-
postpartum?
Okay.
I don't see it on the announcements.
You don't see it on the announcements.
Mhm.
Okey-dokey.
I thought it was just me missing it.
Okay, let me share my screen here. Oh, I was sharing it. Okay, here is your canvas, right? Announcements. All right. By the way, I put your how to resolve the first set of calculations. Professor McBride has a video. Welcome to week 4.
I don't have that on Mine.
Yes, you do.
I don't have it neither.
If you're in
Yeah, I can't see it.
nursing 202 in your announcements,
Mhm.
in your
Yeah, I
announcements.
just checked. I don't see it.
Okay, let me go to student view.
I didn't have
Okay.
it either.
Okay, do you see this?
Yes.
Okay, home is here. Okay, that's home. You go down one more to the left here. It says announcements. Okay, so scroll down. Welcome to week 4.
I don't have it. I can share my screen so you
Yeah,
can see
it's
what it
not
looks
We
there.
don't have that.
I don't have it, Professor.
I don't have it either.
Yeah, one of you share your screen with me.
We
Because that doesn't
have
make
the
any,
Dr. Roberts, and then we have that one, wellness and oxytocin. We are missing the week 4.
Yep,
That
we
is
don't have
between
welcome.
Roberts and wellness.
somebody share their screen. Okay, Emily. Can you share your screen? Just on your Zoom, click share screen on your Zoom. Okay.
Yeah, I have what Emily has.
Yeah, me too. Me too. It's Dr. Roberts,
Yes.
and then it's supposed to be the
Me
week
too.
4, but it's not there. What we have is Dr. Roberts, and then wellness, and then oxytocin. The week 4 is not showing for us.
Correct.
Same
Correct.
for me too.
That is really weird. Okay. April 30th. Let me do this. Now do you see it?
Still no.
Oh, ma'am, not yet.
No.
No,
Do you see the exam 1 study recordings and stuff?
yes, that's
Exam
there.
1 study, but week 4 doesn't come up.
No.
No.
Posted April 30th, 2020. Okay. All right. Now, how about now? You might have to refresh your screen.
It showed up now.
Got it.
Oh,
Yeah.
I
There it
can't
goes.
believe- I don't understand that. That's weird. Oh, if
It's
you
there.
don't see, okay, if you don't see week 5 by Sunday night, somebody send me a text or something, because I'll get it on there by week 5 for week 5. Oops. Okay. If you don't see one for week 5, welcome to week 5. Somebody needs to let me know.
Yes, ma'am.
That is weird. I apologize for that. Well, by golly, you didn't have anything to go by, did you? Okay, So there is a postpartum. I'm going to email this to you, this postpartum PowerPoint, okay? I'll just email it to everybody. That way you'll have it in your email. Okay?
Okay.
All righty. Oh, that's scary. All right. I'll see you later.
Have a
Thank
good one.
you. Bye-bye.
Thank
Bye.
you. Bye-bye.
Dr. Zeller, do you have a minute?
Yes.